This is James Esty with the GVU MSAT program for general medical conditions. This is my type 1 diabetes mellitus and tendon healing patient presentation. So first up, what is type 1 diabetes mellitus or type 1 DM? Formerly called insulin-dependent diabetes, it makes up about 10% of all DM diagnoses. Most patients will know they have this before they turn 20, although that can vary from patient to patient. What happens when somebody has type 1 DM is that the body is unable to produce insulin on its own. Insulin is produced by the pancreas to manage blood sugar in the body. Insulin is also needed for proper use and storage of carbohydrates. So essentially what that means for athletes is that during exercise they are less efficient with their energy stores during exercise. And then when they are refueling post-exercise for recovery, it takes them longer to refuel compared to someone without type 1 DM. So about 2 million Americans have type 1 DM, and about 300,000 of those 2 million are children and adolescents. Most type 1 diabetics are 45 to 64 years old, and men and women share fairly similar prevalence rates, as you can see on the chart on the right. And then people of African descent have the highest prevalence rate out of ethnic groups. So, patient presentation. My patient is a 19-year-old white male football and track athlete, specifically a triple jumper, who has type 1 diabetes. So he has an implanted CGM and was prescribed Ozempic earlier in the year to help manage his diabetes. His Ozempic prescription has been going fairly well. However, he has lost quite a bit of muscle mass since the beginning of the year and his prescription started, and that has been affecting some of his just overall strength in his sports. So he's been dealing with chronic left patella tendinopathy for the past 2 or so years. He's routinely gone through rehab protocols, and every single time he gets cleared, his symptoms come back. So in the latest episodes, in preseason, this patient reported a sharp pain in his left patella tendon during football practice. At the time of his injury, his hemoglobin A1C number was over 7%. So that is important because, first off, his target range is less than 7, and then most people's normal is somewhere in that 4 to 6% range. So A1C is the measure of the amount of glucose in the bloodstream. And then a high number has correlation with risk of injury and then, of course, longer healing times as well, which that is the main reason why diabetics don't heal as fast as someone who is not diabetic. After that initial injury, the patient went through a normal return to play process, eccentric program for patella tendonitis. However, during the advanced stage of his rehab, getting him back to sport specific stuff, he had another episode of patella tendon pain. So he was at practice, he was backpedaling, and then as soon as he took a forward cut, he had immediate pain in his left patella tendon and was again pulled from practice. So after that instance, he was referred to our team physician, who recommended that he see an orthopedic specialist. He was first referred to the Iowa Ortho guys, which we send a lot of our people to. However, he elected to see an orthopedic specialist that he knows back home over fall break, which was shortly after this meeting with the team physician. So after seeing that team physician, they decided on a treatment plan of a PRP injection, which on the right hand of the screen you can see how that works. They collect a little bit of blood, they spin it in a centrifuge, they extract the plasma, and then they re-inject that plasma into the patient's injured area. So after that injection, athlete could bear weight immediately. No crutches or anything like that was needed. And then he was provided Norco and some prescription strength ibuprofen for pain for the following week or so by the orthopedic specialist. So stretching was allowed 24 hours post-op, and he was encouraged to do that as often as he was comfortable. Concentric tendon loading was to begin in week 1, and then eccentric loading may begin in week 2. We took 2 weeks to start concentric tendon loading just to make sure his tendon had time to recover from the injections, as after 1 week he was still pretty sore and just generally did not feel great after that injection. And then eccentric was allowed to begin in week 2, which for us, that was week 3. Currently, we're in week 6, and we have started plyometric loading on a single leg. We're a little bit behind schedule just because we're being cautious, because with his diabetes, we don't want to rush him back and have his body not be able to catch up to the load we're putting on his tendon. But as of the protocol provided by the physician, 6 weeks was when we could start return to sport. And as a triple jumper, plyometric loading on a single leg is very close to sport specific for him. And his A1C and blood glucose numbers are continued to be monitored by patient and by AT staff. So we check in with him every time he comes in. If we're at practice, we have his numbers available on his phone. He gives it to us. We can open the app and see what his numbers are as he's exercising. So we did have one complication arise during his treatment. So again, it's been slow going because of his diabetes. However, that wasn't the main thing. Over Thanksgiving break, athlete left for 6 days, and he did not do his prescribed home exercise program while he was gone. So when he came back, we decided that we were going to start where we left off. Fairly easy day, just to make sure that nothing arose over Thanksgiving break or nothing would happen because of just being inactive. So after that, that was on Monday. Monday night, patient experienced bilateral intra-articular swelling of both knees. There was no swelling directly related to his patella tendon, at least from what myself and my preceptors could find. And then Tuesday, the athlete did not, so this happened Monday. The athlete did not come in on Tuesday to tell us about this. Wednesday he comes in, and then we find out about his swollen knees. Possible causes, we're honestly unsure about exactly what happened. Athlete had a high at an episode of hyperglycemia over the break where he got over 200 plus on his numbers. However, he had no serious symptoms at the time of his episode. He just noticed they were high after eating dinner with his family. He also sat for a while on planes on the way back from Thanksgiving break, although he also flew out and also sat for a similar amount of time. Swelling was resolved over that week with constant movement and continued rehab, which this would have been last Friday. But we did not progress until that swelling had resided. So that swelling was pretty much gone on Friday. So on Friday we progressed a little bit to just progressed his current exercises, still being cautious to make sure that swelling did not happen. So just some of the resources I found and some of the things that will pop up possibly with diabetes mellitus in athletes. So first up with the NATA position statement, trauma and stress hormones. So trauma causes an increased hormonal response compared to non-diabetics. So diabetics will have an increased trauma response. And then a couple of the hormones that get released are cortisol, growth hormone, glucagon, etc. And then these hormones are then correlated to a greater release of blood glucose. And fortunately, my athlete does not have poorly controlled blood glucose or diabetes. However, if that were to happen, we would need to be aware of infections, drastically slower wound and fracture healing. And then again, poorly controlled blood glucose can just be mitigated by proper insulin administration and just proper care of that athlete. So, and then recommendations for athletes with diabetes, maintain your blood glucose at relatively normal levels during an injury recovery. And then from the medical team standpoint is like aim for tight control to reduce trauma's adverse effects on the patient's glycemic balance. My second source, NATA statement continued. More recommendations. So each athlete that has diabetes should have an individualized care plan. Having a generic care plan for all of your diabetics on a sports team or at an institution is not best practice. Each one should have an individualized care plan that should be in their file. And then just some things for an athletic training kit. Have their care plan on file with you when you're traveling with that patient, as well as blood glucose monitoring equipment, and then just like athletes' preferred snacks for hypoglycemic episodes, as well as supplies for urine and ketone testing. For my second source, is there a correlation between diabetes mellitus and tendon healing? There is an association. So this study found that people with diabetes have over 3 times the odds, had over 3 times the odds of developing tendinopathy compared to controls. That control group consisted of people without diabetes. And then people with diabetes also had thicker tendons compared to non-diabetic individuals, which essentially what that means is that damage to that tendon requires essentially more damage because there is more tissue, so healing that also takes longer. Hyperglycemia can also has its effects. So hyperglycemia alters collagen cross-linking. So if you are in constant states of hyperglycemia, your collagen laying down in the recovery aspect of an injury is not as efficient as a normal patient, as well as reducing protoglycan content. So, continuing this article, some clinical implications of the link between tendinopathy and diabetes. Careful monitoring of load progression, just because these patients take longer. Progressing them too fast can cause further injury. And then impact of diabetes management on tendon injuries. Maintaining a lower average blood glucose may support better recovery. Hyperglycemia has the issues with cross-linking of collagen. So maintaining a lower average blood glucose will help us avoid that. And then reducing blood glucose variability, which is postprandial excursions, could be beneficial for tendon healing. Collaborative care is also super important. So the athlete's medical team, consisting of physician, in my athlete's case, his orthopedics specialist back home, his endocrinologist, as well as the AT staff, having a clear line of communication between all of those individuals and having everyone be up to date on exactly where this patient is a key factor in diabetic management on its own, as well as orthopedic injuries with diabetics. So, and then my final source, rehab of tendon problems in patients with diabetes mellitus. So, some tendinopathy characteristics in diabetes. So, in people with diabetes, tendinopathies show less blood flow on some power Doppler ultrasound compared to non-diabetics, which was the control group of that study. This is likely due to some vascular changes or reduced angiogenesis in the tendon lesion. And then reduced blood flow, of course, hinders healing, and then especially so tendons already don't have a ton of blood flow, so that's just going to continue to hinder that tendon healing. So some rehab strategies, exercises for blood flow improvement. So essentially constant movement, pain-free movement to encourage blood flow to the injured area is extremely beneficial for these patients, more so than in patients who do not have diabetes. It was also found that isometric and isotonic exercises were particularly beneficial for diabetes management, tendon injuries and diabetes management. And then controlled tendon loading. So this is again just like a previous study, carefully monitoring the load on the tendon and then progressing it as able to avoid injury is also key for this healing tendon. And just key recommendations from this study. Avoid excessive strain on the tendon. Don't push it too hard. It's better to take more time than to try and rush him back and just have him re-injure himself. And then really, really, really emphasize gradual, controlled progression in his rehabilitation protocols, which is what we are doing with my patient. We are taking our time. Also, and there's just the list of my references. I used 2 extra references from the 3 that we were designated. I use the General Medical Conditions textbook for my diabetes definition, and for my diabetes statistics, I took those from the American Diabetic Association. Thank you.